Good evening, and happy Wednesday, and welcome back to Health Plus Weekly. I am Dr. John Podkowa. I'm joined by nurse practitioner Hannah Raymond, our media expert Peter Kohenna, and we welcome Dr. Elizabeth Blanchard of the Physician-in-Chief of the Southcoast Center for Cancer Care to join us tonight. Thank you very much, Liz, for coming on the show.
Thank you. Thanks for having me.
Tonight's topic, we are going to talk about the Southcoast Centers for Cancer Care and the services we offer here in the community. We're going to talk about, kind of the burden and prevalence of cancer in the country, how we can prevent it, the appropriate screening intervals when to help detect early if it's there, and also the new treatments that are available, and a host of other things that hopefully we can cover tonight. As always, we welcome anyone to send in questions regarding whether it's cancer or any other health issues into the show. We will try to address the cancer questions first and then the general medical questions more towards the end of the show. If you don't want to send in a question via Facebook, our producer Josh will put up on the screen the toll-free text number that you can anonymously text in questions. So without further kind of delay, usually, Liz, we start with asking our guests how they kind of fell into their career and kind of decided what made you decide to pursue oncology.
Sure. So actually going into medicine and becoming a doctor was one of my earliest childhood memories. So it's something that I remember even when I was in grade school. My grandfather was an internist who practiced in Cranston, Rhode Island, and he was the old-fashioned doc who, the patients would call the house and my grandmother would answer the phone. And
really?
He'd go to people's houses with his little black bag. So I remember following him around the house with his black bag, and I knew that was going to be my field. And I gravitated towards the internal medicine training, like you guys, and was very interested in managing complicated diseases. And at that time when I was in medical school, it was really a lot of biochemistry, and that was really the challenge in which drugs are best and which genes are going to cause cancer and which ones we could target. And that really I found very exciting. And it's really important for me to be able to take care of the whole patient. With cancer, the family's an important factor. Someone's activity and their lifestyle and what their goals are is very important. So it's really a very comprehensive field, and a very challenging and exciting field. So,
what brought you to Southcoast?
So I was in an academic center in Boston that kind of fell apart. I fell in love with the area. This had sort of a community feel, which I liked very much, but really a community feel plus. With an academic sort of feel and an academic sort of flavor. So this is really home for us now.
Great. And where do you practice currently?
So we have two centers, one in Fairhaven and one in Fall River, and most of us in the group go back and forth. So we spend time at both centers.
Okay.
And you do some time in the hospital too.
That's right. Yeah. So the way we run our practice, so it's important for us to be available to patients who run into complications, and that's something we can talk about on a number of levels tonight. But so when someone gets admitted, they get seen by somebody in our group. One of us is always embedded in the hospital and on call. So someone's on call 24/7, and it's always somebody from our group, which is important to us. And we all spend a week in the hospital.
And you should know you're on call tonight.
I am.
Yes,
Right.
It's real. It's real.
I think it's really important, I think one misconception that people have is that, but today, cancer really isn't treated in the hospital, though. I mean, because the treatments we've progressed so much that for most of the time, the treatments are done in the outpatient setting. People don't have to go to the hospital for cancer, right?
That's correct. So the amount of times that we give chemotherapy in the hospital, we can almost count on two hands per year. It's really unusual.
Yeah.
It only happens really in emergent cases. The vast majority of oncology happens as an outpatient. Because you can imagine people are going to feel better if they wake up in their own house and they get themselves dressed and they have breakfast in their own living room and they're able to walk through their yard and be in their home environment.
Yeah.
They just do better.
Yeah. It's amazing. I was just watching a television show recently, and the person was getting treated for cancer in the hospital. And I just thought, what an old concept, and how it just really doesn't match with current reality.
Right.
Let's talk about kind of prevalence or of cancer in Massachusetts. I thought I read within the past year that cancer might have actually surpassed heart disease as a leading cause of death in Massachusetts. Is that right?
It's certainly heading that way all over the country. And I think within the next 5 to 10 years, it will surpass it all over. It's with the aging of the population, we've gotten better at treating heart disease, so cancer will overtake it at some point in the near future.
Is that a function of people living longer?
It is partly,
Yeah.
right, exactly. Cancer is largely a disease of older people, so unfortunately that puts more people at risk.
Are there more people getting diagnosed with cancer? I guess people are dying of cancer maybe because they're living longer, but are we getting better at preventing cancer, would you say?
There certainly are good preventative strategies. Has that made a difference on a global level? I don't know those numbers. Certainly, if you take a screening test like colonoscopy, it can find cancers, but it can also prevent cancers. You take something like mammography, it catches cancers at an early stage. So not every screening test can prevent cancer, but can catch it at an early stage where it's much more treatable.
We are, in terms of, sometimes we read disparaging comments about our healthcare in this country, but we're actually pretty good at treating cancer in the United States, aren't we? Like we're doing a good job.
We're in a very fortunate position where we have tremendous resources available to treat cancer. It tends to be very expensive, so hopefully, it isn't available. I wouldn't say the 100% of the population, although we work very hard to make sure that that's the case for each of our individual patients. But we have access to the best in the entire world in terms of cutting edge technology. So we are very fortunate, and that does not happen everywhere in the world.
Could you talk a little bit about some of the subspecialties within oncology? So you're a medical oncologist, and there's radiation oncology and surgical oncology. So what's kind of the difference between those, specialties within oncology?
Yeah, it's a really good question. So for us, oncology is really a team effort, and we often will sit together and bring together discussions on cases because each person brings their own area of expertise. For example, in breast cancer, we sit every Friday morning with the surgical team that are specialized in breast surgery, with the radiation team, and radiation, for those folks who aren't familiar with cancer treatment, is really the giving of energy that focuses on an area of cancer to treat it. Medical oncologists like myself who are more in the medical part of it, giving medications, whether that be chemotherapy or hormonal therapy, as well as sort of the overall medical care of a patient. But there are also radiologists there who specialize in breast imaging, pathologists. So it's really a team approach, and each person sort of brings their expertise to the table, and we come up with a consensus of how best to treat the patient.
Which is why the idea of an actual cancer center works so well, where everyone kind of is under one roof and works together and can walk down the hall and say hi to each other. And other members of the team, that if somebody was being treated in the cancer center, would be what other types of people?
Right, so then the sort of second layer of the team is the myriad of people that help us manage a cancer patient. So cancer, as you imagine, is a really complicated illness that affects all facets of your life, all facets of your family. And we're very fortunate we have two awesome teams, one in Fairhaven and one in Fall River. And that includes our nursing staff. We have a social worker at each site. We have a nutritionist. We have a great group of supportive front desk staff and medical assistants who all feel like they own a part of the cancer management, and they do. And we need all of those folks, really.
Great. So those are the people. Are there particular programs at the cancer centers that are kind of patient support, family support type programs?
Sure. We have two sort of relatively new initiatives that we're really proud of. One of them is what we call cancer urgent care. So unfortunately, when you have cancer or going through cancer treatment, there are complications. And we feel like those patients are best served by being treated within our cancer center and by us. We have the expertise in their illness. We know what the complications of their therapy are. We'd rather not have them sit in the emergency room and get exposed to all kinds of people who are sick if they don't have to. So we've started a program we call Cancer Urgent Care. So we offer same-day appointments, urgent care slots for patients who have cancer or who have cancer-related, treatment-related complications, and they can be seen the same day.
Great. And we appreciate that too.
Yes,
on the primary care side.
Right. The other initiative that we're really excited about is that we've started a breast cancer specific survivorship program. Breast cancer survivors are a unique group of folks. They have their own unique sets of sort of how to get back into life as a cancer survivor. How do you live life now that you've had your diagnosis? You may have some leftover symptoms, or you may not feel like you're back to your wellness self yet. And it's our way of trying to transition people back into their wellness kind of mode. Mindset, exactly. So it's run by our fabulous nurse practitioner, who's done a significant amount of education in the world of survivorship. And she's done a fabulous job helping folks through. And
because there's important things to monitor that in terms of depending on if you had a different type of chemotherapy, whether you need to have your heart checked periodically, and other perhaps long-term effects, right? So it's great that we have so many women who are surviving and survivors that they're watching them and kind of.
And we balance it out with their medical appointments. So people are generally followed in the survivorship clinic, but they don't lose touch with their medical oncologist either. And we're hoping that will be the model to other disease types to do other survivorship programming in the future. Great. So.
And I know we have one other exciting kind of program within the Cancer Center coming up. Do you want to touch on that a little bit?
So you have the Patient Caregiver and Assistance Fund, which is, because cancer, like many other medical illnesses, is not just a health burden, but it's a financial burden for families, and it affects people. The leading cause of bankruptcy, personal bankruptcy in the United States is, medical causes. So one of the great things about our cancer center that you guys have established early is that you have, some resources for people to, when they're going through this, if they need help, right? Regarding whether it's getting a wig, paying bills, treatment for kids, correct?
That's right. And it's a really, really important area because it's such a huge area of stress for patients, of course. So, for example, I saw a patient on Tuesday and unfortunately had to change their medication. They had progressive cancer, and so went through the very difficult conversation and have to change the medication. And the nurse told me today on my way out, it's going to cost $1,000 a month. That's an incredible financial burden. And this is somebody who has insurance. So just as you said, it can be a huge financial hit for folks. So the Patient Caregiver Fund is really set up for people who are in trouble and are going through cancer management. It's essentially distributed by our social work staff who know the patients very well, so we know that the money is being used appropriately. And there are people in real need. These are people that come to us with their electric shut-off notices and need grocery cards and things like that. So it's really 100% of it goes to patients, and it's been a wonderful lifesaver for many people.
So we're actually going to have a 5K race we'll put up at the screen at some point in May. In memory, actually, of my wife who passed away from breast cancer. Dr. Blanchard was actually one of her doctors. It just makes me so happy to see you. To help raise money for that fund, which is, communities together, kind of just one of my favorite things about the Cancer Center, which when Nicole went there, and is the motto, no one does this alone. From the treatment teams of what you guys just talked about, to families and neighbors, it is a hard thing to get through, and it is really wonderful how many people are involved in getting people through it, so it's such a great...
it's such a privilege to know Nicole and to have taken care of her. It's really an honor that we can put her name to something so important and so meaningful.
We should say that the Patient Caregiver Fund was renamed in her honor. Was it last year?
I think so, yeah.
So the 5K is Sunday, May 6th this year. It's held at the Bay Club at Mattapoisett, and we will have a link to the registration for the run, as well as a link to the donation. So if you can't run, or if you can't make it, or if you're afraid that Pete's going to beat you in the race, you can still donate.
Don't be afraid about that.
And 100% of the proceeds will go to the caregiver fund.
And talking really about survivorship programs and how. And the centers are busy. There's lots of people there. One of my favorite experience with you and when you were taking care of Nicole was, one time my wife said, God, it's so busy. There are so many people here. And I'll never forget, you said it was so great. You said, because people are living with cancer longer and longer. It really is. It's such a good thing in terms of the treatments and the, kind of improving length of life and quality of life, and that these treatments are amazing of how much they've improved and are, don't makes people so sick anymore. And all the resources we have right here in our local communities, in Fairhaven, in Fall River, like you said, just world-class access to cancer care, because it's really inconvenient getting sick, and so nothing else should be.
Right.
I think that brings up a really good point, and I know that we try to kind of, when appropriate, counsel our patients on it, that I feel like sometimes people have a perception if you're diagnosed with cancer that you automatically need to go to a tertiary care center, so Boston or Providence or a big academic center, which just isn't the case anymore. So, what's the argument, or, for kind of keeping care local for many cases?
Right. So what I say to patients is that I want you to take advantage of absolutely everything we have available in 2018 in Massachusetts, living outside of Boston. There's nothing that we would say no to, no door we would leave closed. We would want to take advantage of everything possible. The fact is, though, that we can do probably the vast majority of it right here in the community, that there isn't a need to travel to Boston. That being said, we frequently will send people up if we think there's a need. The things to travel for are, so we have a small clinical trials department, but if you don't have a trial that matches one of ours, then that's a reason to travel up there. If you have an unusual cancer, for example, a sarcoma, we automatically send everybody with sarcoma up there for at least an opinion, just because there aren't the wealth of data behind those studies that we can say, this is how you treat it. And there's so many different kinds that really those people should be seen in a tertiary center. People that need transplant, for example, all get sent up there. But oftentimes, even if you're getting a transplant in Boston, we can do a lot of the supportive care.
Yeah.
Whether it's a blood transfusion, whether it's checking your blood counts, whether it's fluids. So we work as a team with whoever it is that's in your care.
And the benefits of local treatment are numerous
in
terms of transportation and convenience.
And our wonderful nursing staff and
it's amazing.
all of those things.
I mean, when you're feeling well, an hour ride to Boston doesn't seem that long, and you're scared. We know it, right? And people we want, but if you get sick or you're having a problem, an hour is a really long time if you're not feeling well or sitting in traffic. Right? If you're having diarrhea from a treatment, or to be able to drive 10 minutes to you or 15 minutes versus. It matters.
That's right. I mean, there are certainly strengths and weaknesses to both places, and there are some reasons to travel. But you walk into our cancer center, everybody knows who you are. We know your name. We know who you are. We remember what your dog's name is, and we're just a much smaller operation, so we can operate more like a family.
That's one of the things that I hear most often from patients who we work with is that you don't feel like a number. You feel like a part of a family. The energy there is just so tremendous and helps people get through, and that's something that they don't necessarily experience in other places. And so it seems like those who have faith in Southcoast Health and try it for their cancer care, once they do, they're hooked. And I can't tell you how many people have said to me, I thought for sure I had to go to Boston, and for whatever reason, I just said, hey, let's go check out Southcoast Centers for Cancer Care first. The moment they walked in, they knew this is where they wanted to get their treatment. So I think it's important for people to stop in and, give us a shot before you make your mind up before you want to go.
Let's talk about prevention. How do we, best case scenario, prevent people from getting cancer? Starting from lifestyle, right?
That's the best
goal.
option.
That's the best, right?
Don't catch it early, just don't get it.
Yeah. Right. And, depending on where you read, about 20 to 40% of cancers may be preventable. So it's a big deal. And there are real intangible things that you can do every day to prevent yourself from getting cancer or to lower your risk. There's sort of two groups fighting for the top of that list. One is smoking, so certainly avoiding smoking of any kind, cutting back if you can't, but keeping that as a goal in your health and within your health goals is fairly important. And then keeping and maintaining a healthy weight.
Which is new, right?
Yes,
in terms of,
right.
So great.
Right. It depends on who you ask that they'll say that's the biggest risk factor. I think obesity is probably taking over smoking as the number one risk factor for prevention.
Is it purely weight, or is it weight and inactivity, or is inactivity as dangerous also in terms of?
You're right. So it's more complicated than just what the scale says.
Okay.
It's really, are you healthy? Are you in a healthy weight for yourself? I mean, there are thin people that are still not in very good shape, and there are heavy people that probably, are mostly muscle mass. So it is really keeping a regular exercise regimen and eating a diet that's healthy and balanced.
Do we have any idea what the mechanism is behind the higher weight or an unhealthy weight or inactivity and the link to developing cancer?
It's an excellent question, and there's a spectrum. So people will come to me and say, I got cancer, I stopped eating sugar because the sugar feeds on cancer. And the fact is that that's really an evolving story, and one that we just don't know all the parts to it. How does insulin play a role? How does weight play a role? And which cancers are that important for? We know that it's important for colon cancer. We know it's uterine cancer, maybe pancreatic cancer. But it's an excellent question, and still really an evolving story of why that makes a difference.
But across the board, weight, healthier weight, more active
Certain
lifestyle.
cancers more than others, but yes.
Great.
Yeah.
One of the things we talk to our patients in the primary care setting, I was just talking with people today, is that in terms of prevention, not smoking, staying kind of fit and active, kind of leading a healthy lifestyle, kind of watching your weight helps prevent a lot. And I tell them, but if something does happen, you're just that much more ready to deal with it. Right? If you're going to have to get chemotherapy, if you're going to have an operation, if you're going to, for whatever reason, like the fitter you go in, just the easier it will be, and to come out the other side, and so it just is, we talk a lot about in the show about kind of health and wellness and kind of staying ahead of the curve, and so I think it's really important that people, it is necessary for prevention too, but unfortunately, people can do everything right and still get cancer.
Yep.
We don't know why, correct? Right?
Yep.
And we just haven't figured that out yet.
Right. So if 20 to 40% is preventable, that means 60 to 80% is just really bad luck, or bad genes, or a combination, or bad exposures, or a combination of those.
Yeah.
Yeah.
So we talked in kind of the prevention scheme. There's like the things that you can control. So your diet, your weight, not smoking, kind of limiting your alcohol. HPV vaccine is another one that we touched on kind of a couple weeks ago with the midwives to decrease the risk of cervical cancer.
That's absolutely a game changer,
Yeah.
right?
Yeah.
You can
Amazing.
prevent it
Right?
from
It's a
the
vaccine that
yes.
can prevent cancer. Yeah.
So those are the things we can control. What are some of the things that we can't control that might contribute to that other 60%?
So there's your genes that we mentioned. Can I just put one more?
Oh,
I want
yeah.
to talk
Please.
about one more
Yeah.
preventable one. So as it gets to be February and March, and winter's really dragging on, which it has been, tanning beds are not the solution to that.
Yes. Excellent.
I know you feel really pale and that feels unhealthy. It's not.
Okay.
That's normal
right.
for February,
Right.
March
Right.
in New England. Tanning beds have become much more popular, particularly among younger folks, 20-somethings, and as a result, melanoma has become one of the larger cancer incidences in people under 30. It's a devastating cancer, so avoid those tanning beds.
Yeah.
And sunscreen when
Sunscreen,
you're outside.
big hats.
Yes,
Yep.
Those are in
Yep.
now, I think, right?
Actually, while we're on this topic, alcohol. Some data, right? Whether it may increase risk of cancer, right?
Right. And our national organization put out an article several months ago with some fairly strict warnings about alcohol. And so certainly it is a risk factor for many types of cancer, breast cancer, for heavier drinkers, esophageal cancer, head and neck cancers. So that is one way that you can reduce your risk, is by minimizing your alcohol use. I think what we used to say is 1 drink per day for women, 2 drinks per day for men. For cancer prevention, that may be a little bit above what you may want to cut back even further to make that prevention true and real.
Diet, in terms of plant-based diet, you know what I mean? Or is there any kind of data that in terms of meat, protein, red meat as well? What are your thoughts on that?
Certainly in terms of colon cancer, that's linked to your red meat intake. And that's, I think, a healthier lifestyle is going to be more plant-based and going to be more whole grain based. So that will help in terms of weight. But specifically, and then the processed meats that have a lot of chemicals and fillers and things like that, there is certainly a connection there.
Okay.
Also to colon cancer.
Also to colon cancer in particular, right?
You know, I think the CDC puts out in terms of the 4 behaviors that lead to most of the chronic diseases and kind of, you know, in this country. It's like, you know, kind of, it's smoking, excessive alcohol use, overweight, and activity. We talked to our patients about. So it's just what you said. So, and those things don't just protect you against getting cancer. They protect you from getting heart disease,
right.
chronic, you know, pulmonary, you know, lung disease, and diabetes, joint disease. So it's not just, you know, you're preventing one, you know, it's just a game changer for a lot of things in terms of prevention.
And in turn, like you said, if you're preventing those kind of chronic diseases, if you are an unlucky cancer, you know, diagnosis, then you're more apt to be able to handle that. You know,
right, and more apt to live longer, despite having the diagnosis.
Yeah.
So the takeaway here is don't eat a steak while drinking whiskey and smoking a cigarette in a tanning bed all day long.
Yes. We sum it up. That's a circle with a red line.
Yes. Okay.
Yes.
I'll avoid that.
Absolutely. Family history is really important also in terms of, you know, kind of protecting yourself, correct, and knowing about it.
Right, because there are some genetic syndromes that we know are set people up to be much more prone to cancer, and if we know what that syndrome is, we can direct their screening so much better.
Okay.
And we can use it. There's good evidence-based guidelines to say if you have a genetic syndrome, for example, Angelina Jolie, for example, has the BRCA gene complex. If you have one of those syndromes, then your screening should be much different than the average population. We can do well to either prevent them from getting cancer or to catch it very early. Yep.
Can we talk about, like, you know, what family history should raise some red flags for people to,
Sure.
you know,
Yeah,
we talk about,
it's a
like,
great point,
yeah.
and it's something that people should generally be aware of.
Yeah.
So any diagnosis of ovarian cancer should prompt a genetic evaluation. Okay. So that's sort of across the board. If you've had ovarian cancer, you should see a genetics expert. If you've had cancer at a younger age, usually we use 50 as the cutoff. So cancer under the age of 50 should also be a red flag. Multiple family members, particularly first-degree relatives. So if your mom had cancer and you did, or if your mom had cancer, that puts you at somewhat increased risk depending on the type. So multiple cancers within the same immediate family, or even a larger family if it's even more incidence of cancer, a higher number of cancer patients.
Is one side is important too? Or maybe not? But if it's like, you know, breast cancer, my mother had breast cancer, my aunt had breast cancer, my mother's sister had breast cancer, my mother's grandmother had cancer.
Exactly.
Versus
right.
Coming from both
sides.
mom and dad, yeah.
Exactly, right. That would follow the genetic line. Don't be fooled also, though, if you can still get BRCA from your dad. So even though it's a breast cancer gene, you can get it from your father's side.
It's actually, I was going to look this up, I was having you on tonight. I saw someone today, and the question we were talking about was his sister had breast cancer in her early 40s, survived, so survivor, tested positive for BRCA. He has 2 daughters, and so he was wondering, you know, in terms of how to protect them, in terms of whether he should be tested or not, and do we have genetic testing at Southcoast now? Or, you know,
we have a fairly limited program at Southcoast. Okay. It's really hard to hire a genetics counselor, actually. They're very much in demand. So we have a very small sort of program only within the confines of the Cancer Center at this point. We're hoping to enlarge it, but at this point it's very limited, and it's really just a pilot at this point.
Okay.
So we we often send people out for that, unfortunately.
Yeah, to other Providence, there's a center,
Providence
right?
is a center in Boston.
In Boston,
there are
can
several,
do that. Okay.
right? But that's somebody that certainly should be tested.
So would he be tested?
He would be tested.
He would be tested. Okay, great. And then colon cancer. You know, so ovarian cancer, breast cancer is at a young age. Colon cancer, uterine cancer can be part of of a family as well, correct?
Correct. So it's a little tricky. Those are also the most common cancers, which makes it a little hard to distinguish. But certainly any of those cancers caught at a young age, particularly on one side, as you mentioned. But there is there are several syndromes. One of the more common ones is Lynch syndrome, which has that group of cancers as part of their genetic risk. So colon, breast, endometrial cancers within the same family should prompt an evaluation for something like Lynch syndrome. And for people with Lynch syndrome, we have very focused and aggressive screening programs so that we either prevent the cancer or, again, catch it early.
What about pancreatic cancer?
That's a difficult one to screen for. As you know, the pancreas sits really low in back of the belly, and it's a hard one to diagnose. So there aren't good screening tests for it.
If people have a strong family, like, my grandmother had pancreatic cancer, is there any different recommendations for them?
There are different recommendations because the chance of having it's not a very common cancer, and then the number of patients that have a genetic syndrome is pretty low, like in the 1 or 2%. So it's such a small population of patients. But if you did have a significant family history, it's worth at least seeing somebody from genetics.
Right. Okay. So we have a question actually from Dan, pretty similar to what you just asked. He is asking, his sister had breast cancer and had the BRCA gene. Some people have told him that he should get genetic testing for his 2 daughters' sake. And so you just answer that as yes.
That's right. He should be tested because, first of all, it has implications for his health and his screening. But also, if he's positive, then that would prompt testing for his daughters. If he's negative, then he didn't pass it on, and they can be, they can rest assured.
Okay.
Great.
So if he was concerned about that and wasn't being followed at the cancer center, who should he contact for that referral?
Yeah, Women and Infants has a program, and then any of the tertiary centers in Boston have them also.
Okay.
So.
And I guess we can move on to the next step in terms of when to begin screening for certain cancers, because based on your family history, you may or may not move your screening earlier, correct?
Right. So our sort of kind of old rule of thumb is 10 years before your incident cancer. So if your mother had breast cancer at age 40, then you would want to start screening at 30. In that case, you'd go through genetic testing, but if you were negative, you usually start about 10 years before. That's kind of our general rule.
Across the board for all cancers?
It's a general rule. It's not even really all that science-based, but it's sort of
feels good.
Yeah, it gives us plenty of wiggle, of lead time, right?
Other type of, before exposures, certain people be worried about. I think perhaps one of the most commonly known exposures is asbestos exposure.
Right.
Can lead to a form of cancer called mesothelioma of the lung. Any other kind of people who are from an occupation standpoint should be more worried?
Yeah, there are certain chemicals that can cause certain types of cancers, bladder cancers, blood cancers. Hopefully, many of those patients who are exposed in this day and age are given the proper protection, the gloves, the masks, that should be up to date. If they're not, then obviously
call OSHA.
Call OSHA. But there are still some exposures out there, unfortunately.
So I guess in terms of moving on to routine screening, in terms of really important, kind of reasons why you want to go to the doctor if you're not already plugged in with your doctor, in terms of as we move through when to start, thinking about cancer screening. It's at the American Cancer Society that has it broken down by ages, so we can go through. So I guess the earliest people who have to start worrying about cancer are women, correct?
That's correct, and particularly cervical cancer. The cervical cancer screening is one of the most successful screening tests that we have. And it's not fun, but it's not horrible either, and it's very, very effective. So getting a pap smear on a regular basis and an HPV test is incredibly important.
And we spoke about this with the midwives when they were here, but even though you don't have to get a pap smear every year, it's still important to get a pelvic exam every year because there is a difference. People automatically associate the pap with a pelvic exam, but they are different. So there's implications for other types of, you can feel ovaries and uterus during the pelvic exam, which is, like you said, there's no exact screening for, those types of cancers, but certainly makes it somewhat easier to detect if something's going on.
Right,
Yeah.
right. It's an important exam.
And so that starts at 21 for young
21,
women, correct?
Correct. And that's new, relatively new guideline. So men of that age, men age 20 to 30, unless you have a family risk, kind of off the hook.
Off the hook in terms of screening, right?
Yes.
Right.
But not prevention, right?
That's right. Exactly. Right.
And then again, kind of next stage is, I guess it's, age 40 to 49. Women, we'll talk about first, some people recommend starting breast cancer screening. It's assuming there was no family history, right? No one, that there wasn't any high risk. Some people may want to consider starting breast cancer screening, which leads us to a topic of like, how do you balance, there's different recommendations and viewpoints out there. So I know, when probably Hannah, you too, patients are confused by that. Like, what should I do?
Sure, and it is confusing and it's hard to know. Although the bottom line is that mammograms are more effective in older women, and that's a product of a couple of things. It's just easier to see their breast on a mammogram when they get older.
Okay.
So it's harder to see a cancer within a younger woman's breast. Although it's still important between ages of 40 and 49, we still do pick up some cancers. It's not as effective for all of those reasons, but it's still a reasonable screening test at that within that age group.
Okay.
And that's what I would recommend, although you're right, there are people that differ in that.
Yeah.
So it's really a conversation. This isn't going to be as high yield as, say, it will be in 10 years, but it still may pick up a cancer. Are you okay with knowing that it may pick up other stuff that might cause you a lot of worry, but may not turn out to be anything if there's a chance that it can catch a cancer?
Yeah.
So the downside of screening would be those kind of false positives that lead to more diagnostics, which may ultimately turn out to be normal and negative, which is reassuring, but kind of that middle time is distressing for some people.
Right, exactly.
So that's the conversation that I know that we have in primary care, with the variation in the guidelines. So your recommendation would be to just kind of have that conversation.
I think for most women, it's really up to them whether they think that worry is really worth it.
Yeah. To your point, I try to talk to patients about different types of way you detect for cancer and why pap smears and colonoscopy and colon cancer screening is so good because we understand that it goes from a normal tissue to a slightly abnormal tissue to a precancerous tissue and then ultimately to cancer. And if you go at the right appropriate times, you should never be surprised by a cancer, and why it's so effective versus mammograms, and which is a picture, really, right? And we try to get the timing right of how often to do it, but unfortunately, all it is a single fragment in time. So that's how a woman can go. Sometimes they're confused. Like, I had a normal mammogram last year.
Right.
How do I have a lump in my breast 6 months later? And it's because it's not as good as, unfortunately, we don't have that yet. And I understand
it's not a perfect screening test. Although our screening has gotten better here at Southcoast, we use tomosynthesis, and that's better at detecting both normal and abnormal tissue, particularly in dense breasts. So that's a real advantage.
Which is
screening.
Especially we have it for young women because a lot of women get that letter in the mail that they have dense breasts, and they're worried because does this mean do I have a higher risk of cancer, or does it mean that their breasts maybe aren't as easily visualized than something's hidden? So Southcoast instituted that a couple of years ago, right? The 3D mammograms.
And that's for everybody.
Yeah, I think it's pretty universally used. You can certainly request it, or if you think a patient's appropriate for it.
So men ages 40 to 49, what are they on the hook for in terms of screening? It's prostate cancer, but again, kind of a conversation surrounding that. And what are your thoughts on prostate cancer screening?
So it is a conversation in the office. Prostate cancer is tricky. So fortunately, most men that are diagnosed with prostate cancer will die with it, not of it. Okay. So it tends to be an indolent type of cancer in many men. And the treatment is not always easy. So it can result in erectile dysfunction, it can result in urinary incontinence, a real lifestyle difficulty for men who go through treatment. So if there were men that you didn't have to treat, you wouldn't want to.
Right.
But we're not all that, we're not certainly not perfect and probably not all that good at figuring out who doesn't need to be treated. So that's where it gets tricky. And if you get a PSA, which is the screening test for prostate cancer, and it's abnormal, can you live with that and sort of live with just watching things? Or would you feel obligated to do something about it and potentially, impact your lifestyle, maybe even if you didn't have to?
Right.
Now, that being said, I still think it's a valid screening test. And in fact, it's sort of, the pendulum has swung back, and there was a recommendation a number of years ago to stop screening. We did see an uptick in metastatic disease, unfortunately. So the number of advanced cases went up. We saw that here in our data, and we saw it nationwide. So the pendulum has swung again, and there's a recommendation to at least consider it. So it is something I think that's still valid, although it's a very long and difficult conversation, as you probably go through in the office.
And then 50, it starts for colon cancer, right? Unless there's a family history, then we move into for both men and women,
right?
And then it's colon cancer, which it has a significant burden in our community, right? I mean, so we see, not even hand, but like a lot of people, say, oh, I think I'll know, or in the reality you won't know until it's too late. Our colons are large; they're not. We don't have a lot of feeling in them, and a lot of different things. So in our community, what's the burden of colon cancer in terms of what you see at the clinic?
We are as a group, as a population, we are underscreened by a significant amount, and there have been some significant efforts. I know by Kathy DeSonis and Dr. Percolo and our cancer group to try and increase the number of screening tests that go throughout the community and try and get more people in for colonoscopies. I get it; it's not an easy test to go through, but it's over in a couple of days, and
there are other ways to screen for it. We were actually having this in this office.
And Kathy actually asked the question, kind of comparing the different types of colon cancer screenings between, a cold blood testing. There's the Cologuard or the Fit Kit that we use at Southcoast, and then versus a colonoscopy. So could you speak a little bit about the different screening measures?
So probably of those, the fecal occult blood test is the most crude, if you will, or the most simple. So that does detect blood in the stool, which can be a marker for a cancer being there. So it's good if it's positive. If it's negative, it's not all that reassuring and doesn't really rule out a cancer. The Cologuard and the Ensure Fit testing is much, much better at detecting a cancer. And that has never been compared head-to-head in a study, but is considered equivalent by many people, and is certainly better than nothing.
Nothing, right?
In getting a test. So,
and that actually detects the DNA of precancerous
That's
lesions
correct.
that could
Right, it's not just looking
on.
for blood, right? Exactly.
We just had an update on that last night. I didn't know.
Sure.
Yeah. And people can do this at home. So the benefits of those is you don't have to do a prep. You can do it at home. It may or may not be cheaper depending on your insurance, because that's a big barrier for a lot of our patients now with these high deductible plans. We get them to convince them to do a colonoscopy, and then they find out that it's going to cost them $250 to $1,000. So,
exactly.
But we talk to them about ideally why colonoscopies are great, because they look through everything and they can see, and if there is something there, they can treat it at the time of the procedure.
That's right. So if you have a colonoscopy and you have a precancerous polyp, it gets removed. And then your risk of colon cancer from that polyp is 0. It's gone. It's removed.
And then we know that you need to be screened a little more frequently.
Right.
Unfortunately, if
exactly.
you don't enjoy the colonoscopy, but we have good science on that as well.
What about lung cancer screening?
So that's a really important one, and we have some of the highest smoking rates in the state in our general area, and that's another screening test that works very well. And if you can catch lung cancer at an early stage, it's a complete game changer for that patient. Advanced lung cancer, unfortunately, it tends to get caught at advanced stages. People have a cough, they might ignore it, they might think it's pneumonia, they might get some antibiotics, so it tends to be caught at a later stage. And it just sits in, it just is insidious.
They may not have any symptom, right? They go to the hospital for something else and they get a scan.
Right, exactly, exactly.
So eligible for because we have a lung cancer screening program at Southcoast, so eligible people for that program, 55 and older.
Correct.
What other criteria?
So it's a 30-pack year smoking history, and for people that aren't familiar with that terminology, that's the equivalent of smoking 1 pack per day for 30 years. And you can divide it up. I may have to pick up for basketball,
Sure.
by the way.
Okay.
You're on call as a mom too, yeah.
Yeah.
So that means you either smoke 1 pack a day for 30 years, but if you smoke 2 packs a day for 15 years, that's the equivalent. So it's the equivalent of 30 pack years. And it's a
And
low
no
dose.
active signs of cancer also.
Correct.
Okay.
Right.
And what's the screening?
It's a low dose CAT scan, so the amount of radiation they get with the CAT scan is very, very low. And it's done yearly to detect small nodules or an early stage cancer.
I think the last time I got an update on the numbers was a few months ago, and I think we had 250 people in the program that we were monitoring, and we had found 6 cases of early stage, either a tumor or some kind of growth, and had treated those patients well. They had, great results. So far, so good.
So if we can catch people at that stage, they can undergo surgery, sometimes focused radiation, and be cured of their cancer. It's a great outcome.
Yeah.
Now, other programs that Southcoast has for screening, this is there's a free oral cancer screening. Is that correct? Can you talk a little
that's
bit about
correct.
that?
Right. So oral cancers can be devastating if you get them, and they're increased in patients that smoke, if you chew tobacco. Alcohol can put you at risk for head and neck cancers. So we're going to do a screening. We do it every year, actually. It's on one of the docks in New Bedford. The address is 114 MacArthur Drive. We'll have the van out there, and it'll be myself and one of the ear, nose, and throat doctors, and we'll be checking people for oral cancer. So make an appointment or come down. It's a really important thing, again, to be caught early where it can be treated and cured.
And if people could make that, but also may smoke, may drink, like in terms of a good prevention, going to the dentist, right? Seeing your doctor, having someone
That's correct.
look in your mouth. I mean, right?
Mm-hmm. That's essentially what the screening involves, is looking through your mouth. So.
Yeah.
And what about when to stop screening? There's a lot of kind of debate about that too.
There is a lot of debate,
Yeah.
and I'm probably biased the
Yep.
wrong way. Or maybe the wrong person to ask, like never.
Yeah.
So, I think it really comes down to a conversation with the patient. And what I say to my patients is, if you're out gardening and you're going to the grocery store, then probably some screening still may make sense for you. But it's a conversation, I think. When there are guidelines out there, I think the guidelines are guidelines. I think it really comes down to an individual conversation.
I think so too. I think a healthy appreciation of if something was found, the patient, he or she could tolerate the treatment you would offer, because if you couldn't even tolerate the treatment, right, that's not, what I mean. But and also their own wishes, and some people, it's funny, we see them, every day, and some people just kind of say, I don't want to worry in a way anymore, and but one thing we do talk to them about is, and I think there's a misconception that once you get to a certain age, it's not going to happen. And actually, unfortunately, it's not that. The older we get, our cancer risk increases pretty much across the board, correct?
That's correct.
Yeah.
Right.
But we try to talk to our patients that if you, just like you said, if you have great quality of life, if you're enjoying yourself, if you're going out, and you want to keep doing those things, and you are healthy and well enough, because back to our earlier point, most of the treatments now are so amazingly, I don't want to say benevolent, but not as hard as,
like targeted,
right? I mean, it's
a little more focused.
and
Yeah.
it's something else we want
Right.
to talk about. There's a lot of new treatments, and even the older treatments, there are ways to get people through them where they're not so sick.
That's correct, sure. And particularly in the areas of used to be, even before my generation of oncologists, that the nurses would just give out buckets and people would just be throwing up all day in, day out on the oncology wards. We just don't see that anymore because of the advances that have come with prevention.
When I tell people, because they're so scared. I mean, like when patients, they're scared for so many reasons when they get the diagnosis of cancer. One of them is the fear of the treatment and what that's going to be like. When my wife was diagnosed, I always tell people about this. I mean, she never threw up. Nicole never threw up once.
That's great.
Through all her treatments, ever. I mean, she ran through her treatments, and so I think it's an important perception to get out there too, because I think people sometimes don't go back. We've seen this, where people get the diagnosis and they don't come back, or they get mad, or they're afraid and they don't want to deal with it, or I'd just rather not know. But I think a big part of the show tonight is to make sure people that actually the treatments aren't that bad. I mean, they're not always easy, but you've done such a good job, your community, of either improving the treatments and the side effects, or making medications to help deal with the side effects of the medications.
Right. And this is what we do. We sit with patients and say, what are your values here? What's important to you? And what are you willing to put up with in return for what amount of benefit? And sort of come up with a treatment plan together.
There are some exciting kind of new developments in the treatment of cancer care, kind of using our own body's immune systems to target cancer. Could you talk a little bit about some of the
Sure.
and the specific cancers that you can use them for?
Sure. This has been a really exciting area for us. So traditionally, cancer, as you know, is a growth. So these are cells that grow uncontrollably. And to stop growth, we would give chemotherapy. Those are sort of growth-stopping medications. Now, unfortunately, it would stop growth of normal, healthy tissues too, like your hair cells and your blood cells, and those are where the side effects come from. So over the last, I would say, 2 to 3 years, there's a paradigm shift in using what we call immune therapy. And we still use both frequently, but immune therapy has become a much more prevalent treatment. Now, if you imagine, cancer is foreign and it shouldn't be recognized as part of your body, so your immune system should pick it up and get rid of it. But cancer itself, and for a number of reasons that have to do with the immune system is sort of blind to it.
Okay.
So the development of these medications actually take the blinders off your immune system and let your immune system go after the cancer instead. So it's, as you can imagine, most people feel great.
Because it's only targeting
the abnormal cells, right? And what your body would consider foreign.
Wonderful.
And for some people, it's amazingly effective. Not
What
for
type of
everybody.
cancers? Yeah, like what type of cancers are we seeing good success with it?
So lung cancer
Lung
primarily,
cancer,
partly because lung cancer is the #1 cancer killer across the country, in our center, but everywhere.
Did it get the
and
most attention in terms of studies?
does
Is
not
that-
get the most
No, it
attention,
doesn't.
unfortunately.
Okay.
The research dollars pale in comparison to the amount of morbidity and mortality it causes, but it does happen to be fairly responsive to immune therapy. So it's one that we're using in lung cancer quite a bit. And for a certain percentage of patients, they'll have responses that last for months or even years, which is a complete game changer in the world of lung cancer, really.
Wow.
And it's really good quality of life. I got a postcard from Portugal from one of my patients on immune therapy.
That's
Currently
awesome.
on the therapy.
He was on the
Wow.
therapy, felt great, and was able to travel. And so it has been a real paradigm shift for us. So lung cancer, melanoma is really where it started,
Okay.
and where it's been amazingly effective as well. Kidney cancer is another one. Some liver cancers. Breast cancer has not seemed to fit as well with immune therapy. There are other markers that we use in breast cancer, but it's used very infrequently there. And in certain likely hereditary GI cancers.
Okay.
So of the certain hereditary type, they seem to be more sensitive to immune therapy.
So more to come. on
More to
that.
come,
Good.
that's right.
Good.
Yep.
And you mentioned earlier, which I think maybe just so people can understand about if you have a cancer, or depending on, and they can, when they come to you to work with, sometimes they go into a trial. And let's talk about what that means and why that people should, be who that's appropriate for, and what does that mean when, are you in a trial, or should you be enrolled in a trial, or what someone like maybe Dana-Farber have working with you, like some medications aren't approved yet for everyone, but they're looking at them, right?
Right, exactly. So thanks for bringing that up. It's a really important part of how we practice, and it's an important part of our cancer center, but of cancer management in general. So our clinical trials program is run by one of my colleagues, Dr. Sonia Sang, and we have a number of trials open. And the importance of that is that we want to be part of moving the field forward. And cancer trials, one of the big misconceptions and why people don't do it is they say, I wouldn't want to get a placebo. Like, you wouldn't want to not get treatment. And, of course, we would never refer anybody to a trial that you wouldn't get treatment. So by and large, cancer treatment trials are testing what's really standard now, or what's the best therapy we have, versus what's the best, plus what's also the next best.
So everyone's getting the standard
Everyone's
of
getting
care.
at least the standard of care, plus what may be the next best therapy. So it offers patients the chance to get what may be the next best therapy. For example, we had an immune therapy trial combining chemotherapy and immune therapy before we were doing that. So we were able to treat patients with both the combination, which we now know is the better combination.
Yeah.
So we were able to do that for patients way before it got approved as part of a clinical
And
trial.
as part of being part of it, often the patients want to get the medications for free, often
correct.
and get
They
a
do.
host of other benefits,
Right.
and it's monitored really safely.
Yeah,
pretty
it was
close follow-up.
It's
also,
incredibly
yeah.
close follow-up, yes, which is great because, and that's the sort of cancer center that we want to be, is one that that operates on the highest levels and that is eligible for doing clinical trials. So we're happy to be part of that level of oversight. We think that brings our program up.
I was going to say, forgive me, but I want to steer the conversation away from cancer and want to address kind of a conversation that we've had in the comments here, and it's started, like a lot of the comments start, it's wondering if you have capacity and how someone could become your patient, and then it kind of has turned into a conversation now about general capacity for primary care docs at Southcoast, and how someone, Tracy has been having a hard time finding a doctor, looking for someone that she can trust. What is your recommendation as far as first and foremost, who are a couple doctors that you would recommend, and then just generally, what would you give for recommendation as far as how she should go about finding?
Sure. So on our website we have the Find a Doc number that you could search by specialty in primary care. And so we have a number of new primary care doctors actually who have come on board over the past year, and a couple new ones who are still going to be coming on. So in the Fairhaven practice where I'm working right now, there's Dr. Kevin Gendro. He's accepting new patients. He was on the show a couple of weeks ago. If you want to watch the show to introduce, and see what he's like, he's accepting new patients. There is other doctors in the Dartmouth area. Dr. Brett Hertu is accepting new patients who's excellent. Dr. Theo Addo is in Dartmouth as well. Excellent, smart. I worked with him. Know him well. In the pediatricians, depending on the age, is also we have in Dartmouth. In the Fall River market, there's Dr. Tessa Draper, who is one of the new, women doctors. Family medicine. He's really great.
And we should say that we're, kind of moving forward in the show. We're planning to highlight some more of the new physicians that are, coming into the South Coast, community, with hopefully, connecting people who are in need of primary care doctors to the new providers here.
And I think those primary care docs that you mentioned, you would feel comfortable going to see as a patient.
Yeah. I'm actually part of recruiting. I in part of my role at Southcoast is interviewing and recruiting the doctors, and we are really lucky to have them.
And I've had an opportunity to meet Dr. Gendro a few times now, and I can tell you that if I was looking for a primary care doctor, he would be someone that I would be more than comfortable going to. He has, local guy, born, raised in Fall River, understands the region, and is just overall really nice and great guys. So there are.
And Dr. Tessa Draper and him actually trained together. They were colleagues in residency. So
and so Tracy, there are options. Again, if you go to southcoast.org and you go to the Find a Doc page and you search for primary care, it actually will show you a Make an Appointment button next to the doctors who have capacity, who have openings for new patients, and so that makes it really easy. You don't have to kind of call each doctor and get the news from them that they don't have any room for new patients. You can actually see, and then you can call those who are accepting new patients. And again, Dr. Gendro, Dr. Draper,
Dr. Addo, Dr. Hertu.
Dr. Hertu is very well known and would be a great option. So there are definitely options, Tracy. So please keep looking, and you can always contact our office in the marketing department if you still have trouble finding someone.
Good.
Any parting thoughts? This has been a wonderful discussion about kind of the services that your group provides at locally and within the community here, and all of the kind of screening measures that we take on every day. Is there any other thoughts that you'd like people to know about what you do every day?
I think the most important thing is that there are things that you can do on a tangible day-to-day level to prevent your risk of cancer. Avoiding smoking, keeping a healthy weight and an active lifestyle, avoiding things that are clearly cancer-provoking, like tanning beds and excessive alcohol use and things. But there are real things you can do that are good for your health that are also good for preventing cancer.
Great. And we should be unlucky. We have wonderful resources
Right,
here.
right.
Know your family history. Talk to
Know
you.
your
You know,
family
history.
we have a holiday
Yeah,
coming
holiday,
up in the
Easter,
family,
that's
and so
right. That's
you know, it's good to know.
Hot topics there.
Absolutely, family history.
Can I just plug the race one more time?
Please.
Josh, if you don't mind throwing that back up there. So last check we were at 200 and
Yeah, a little bit over 216. I think runners are signed up
yeah,
for the race.
In only a few weeks that it's been open,
Yeah.
which is amazing. I mean, I think our goal was we were told basically by experts that you'll get 150 people in your first year of doing a race, and we've already surpassed that. And I think our goal now is to get to 300.
Mm-hmm.
Hopefully we'll get there, and then we'll figure it out next. April 1st is the deadline for early bird registration. The registration will go from $30 to $35, and then you're not necessarily guaranteed to get a T-shirt. So if you are interested in running, sign up before the 1st to make sure that you get that discount and that you get a T-shirt. I think we're all running here, and I think it's going to be a lot of fun, and so sign up.
Wonderful.
Awesome. Liz, thank you very much for coming on the show and taking an hour out of your very busy life, and hopefully you can get basketball pickup done.
Thanks very much for having me. This was really fun, guys.
Yeah,
Thanks.
yeah, and thank you very much for all your help and caring for our patients as well. And it's a privilege.
Happy
working
to.
with
It's
you.
a privilege, really.
Thank you everyone for watching this week. Thank you, Josh, our esteemed producer, for running a great show. Hannah, Pete, we'll see you next week. Stay healthy, South Coast.
By the time I graduated high school, I think I was between 275 and 300. I had to buy my dress clothes at the Big and Tall store. Enough is enough. Southcoast Health gave me the tools, and here I am, with my health. And I was a 46 going into a 48, and now I'm a 30-inch waist. I'm living proof to show if you put the work in on anything that you can get what you want. Take impossible, throw it out of your vocabulary.